Hey everybody, welcome back to the ECG channel. My name is Reid, and don't forget to download the PDF of today's ECG document down below in the description, and like this video and subscribe to the channel if you enjoy the content. So let's jump into this one. So the first thing we're going to do with every ECG is we're going to look at the forest, and the trees of the forest are my QRS complexes. And so if I look down here, maybe at V5, you can see I have two different QRS morphologies. Okay, I have this narrow, and you see we've got a couple narrow beats throughout this rhythm. And then we also have these wide beats, right? We have these wide QRS beats. And I notice at least, that when the narrow beats start, they always start a little earlier, right? If you look at the interval, it's a lot longer than the normal QRS to QRS interval. Excuse me, it's a little shorter, right? This interval right here is shorter than the wide to wide, right? This seems like these narrow beats occur a little earlier than we would expect based off of if we just look at this wide rhythm that's going. If we want to get an average rate here, we know that this is a 10-second ECG strip, so we can actually count the number of QRS complexes. So we would have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. And so if we did 11 times 6, which would give us the total number of beats in 60 seconds, we'd get an average rate of 66 beats per minute. And so now it's like, well, what is going on? Well, I know that the wide complex beats, if you look closely at these wide complex beats, I notice that there's this little spiky deflection just before every QRS, just before every wide complex QRS. These are pacing spikes. And when a pacing spike occurs before a QRS, we know that this is a ventricular pacing spike, right? It's shocking the ventricles, and the ventricles are depolarizing from that point on, creating this wide complex QRS. Why does it create a wide complex QRS? Well, you've got a wire from a pacemaker box that's going all the way down into the ventricle. And so anytime it paces, you get slow depolarization from cell to cell junction through the ventricles, right? And so that's why we have, generally in those wide complex QRSs, negative QRSs in my inferior leads, right? My inferior leads, I see negative QRSs because that impulse is going away from those leads. So, okay, we've got some ventricular pacing. You can tell that the ventricular pacemaker is beating at a very regular rate. Notice that every pacing spike occurs exactly like 2 boxes from that solid line, 2.5 boxes from that solid line. It's very regular, incredibly regular, and it's occurring at a rate of, if I go from here, 300, 150, 100, 75, 60 beats per minute. That tells me that the ventricular pacemaker, it's 60 beats per minute between every ventricular pace rhythm. That's probably what it's set at. So I'm like, well, I wonder if the atria is driving this rhythm. So I look for atrial activity. I look for it before the QRSs that are narrow, because I know narrow QRSs means that these were conducted via the AV node, right? And so I don't see any really great atrial activity. And so what's actually going on, you can see it best in lead 2. You can see there's this baseline kind of small fibrillatory type pattern. And so what we have here is we have somebody who's in atrial fibrillation. And so you're probably asking, but I thought atrial fibrillation has an irregular rhythm. Well, if somebody has atrial fibrillation with a pretty significant AV node block, then those fibrillatory waves that are occurring here in the atria that are going to be fibrillating all around, right, and they bump into the AV node, and that's why the AV node usually captures it and sends it down. But if I have a pretty high level AV block, it's not going to be very easy for those waves to make it through. It'll happen very rarely. If it's a complete AV block, you'll never see it. But if it's a pretty high grade block, you'll see it very rarely. And so what's actually happening here is this person is an AFib, and their ventricular pacing wire is set to beat every 1 second, right? So it's set to beat every 1 second. How do I know it's every 1 second? Well, because my rate between ventricular pacing spikes is 60 beats per minute, and there's 60 seconds in a minute, so I know it's 1 beat per second. So every second, it's set to beat. And so what happens is since this person is an AFib, the pacing wire is just waiting. From the time that it recognized the last beat, it's waiting in that timer. So we have we have our pacing spike and we have our QRS, and then that starts a timing system, right? It starts to measure from that moment. The pacemaker lead in the ventricles is waiting. And right here is 1 second. That is 1 second, okay? And so now we're waiting, and we're kind of at this flat line, baseline, baseline, baseline. That ventricular lead is waiting, and if we get to that 1 second mark and we haven't had a beat that conducted through the AV node down to the ventricles, we get a pacing spike and we get a QRS, and then we go back and we're waiting, right? And so then we reset the clock for another 1 second, right? These are ones. We wait for another 1 second, and so if the AV node then decides to conduct a narrow QRS through, then it resets the clock, and it resets it from when the beat started. So it resets it for another 1 second. So let's talk about what we see here. We see these narrow QRS complexes that occur before 1 second, right? If we measure the rate from the beginning of this QRS to the beginning of our narrow QRS, we get 300, 150, 100, 75, 60 would be here, so it's a little bit before 60. That's like 65 beats per minute or so. So when the AV node goes faster than 60 beats per minute, we get our narrow complex QRSs. But then look what happens here. This is our QRS complex start for our narrow, so it's the last time the AV node sent one down the ventricles. And then you see a pacing spike here, and if we look at the rate, we have 300, 150, 100, 75, 60 beats per minute, right on the dot. So this pacemaker is performing flawlessly, set for its cycle time to be at 60 beats per minute, or recognizing every beat per second, right? So if it doesn't have a beat that conducts through the AV node in that 1 second window that it sensed, it will fire off, right? It's obviously not going to fire off in the atria because we're having an atrial fibrillation, right? So this person has AFib with a pretty high-grade AV block. We can't characterize the AV block because, well, we don't have P waves, so we don't really know based on this ECG, but we know that they probably have some level of an AV block. And so now our job is to continue. We can evaluate these narrow complex QRSs. We can see here's one, and if we kind of go all the way up, we can see that the QRS is upright in lead 1. And unfortunately, I don't have a QRS that is negative, or that is narrow in my AVF leads, because timing-wise, we just didn't catch one. But you can see that my narrow complex QRSs, if I look up in V6, you can see that they are going towards V6. They're pretty narrow, so I would say that's okay, right? We have a decent, conduction through the ventricles, right? It's narrow. I look for any infarction, so I can look for ST and T wave changes. I can look at them in my normal rhythm. I can look for them in my paced beats, right? We know that in the ventricular paced beats for infarct, we use something called the Scarbosa criteria, because we know that there's ST and T wave strain when there's paced beats, and I don't see any of that here. And so what do we have? Let's put this all together. It's a pretty fun rhythm. I hope you guys enjoyed it. We've got an atrial fibrillation, predominantly with ventricular paced rhythm at 60 beats per minute, with intermittent AV node conduction, right? So we'll call this intermittent AV conduction. So I hope this helps you kind of understand the physiology behind the AFib with AV blocks, and then how a ventricular pacemaker really plays a role in maintaining a perfusing rhythm. So if you have any questions, put them down in the comments, and if not, thanks so much for watching. I hope you enjoyed this video, and see you on the next ECG. Have a great rest of your day. Take care.